live. Okay, so now we are going to discuss a very important aspect. We were discussing ear yesterday, and today we'll continue the same. We have limited amount of time, that is absolutely 40 minutes, and in that we are supposed to study 1,000 flashcards, no matter whether it's difficult or tough or any kind of, but we need to do it. Okay, so let me find my pen. And the key. Okay. Oh my goodness. I'm so sorry for the delay of 2 minutes. Oi. Okay, so now let's quickly do it. So we are discussing ear. So, hmm, what is the dreaded complication? What is the dreaded complication of otitis externa in older patients with diabetes? So this is called as malignant otitis externa. In malignant otitis externa, what happens? Because of diabetes, there is uncontrolled infection, and due to which there will be involvement of the bones also. Okay, and so this will lead to the more complicated thing. Okay, so this is an invasive otitis externa with osteomyelitis. Bones will be involved, that is called as osteomyelitis. Nerves will be involved. Okay, so there will be loss of sensation and all. Otitis externa में क्या होता है? So there is inflammation of external auditory canal, most commonly due to otitis externa, normal otitis externa. It is due to pseudomonas. It is due to what? It is due to pseudomonas associated with water exposure. If water exposure, this is called swimmer's ear canal trauma or occlusion. Because of hearing aids, occlusion can occur. Parents with otalgia that worsens with ear manipulation, pruritus, hearing loss, discharge. So parents with otalgia, it presents with otalgia. Algia is ear pain, algos ear pain. Otto means ear, algos means pain. So that worsens with ear manipulation, pruritus, and hearing loss and discharge will be there. There will be itching, pruritus, hearing loss and discharge. Hearing loss will be conductive type of hearing loss. Conductive hearing loss. What happens in conductive hearing loss? Release will be, tell me quickly, tell me, release will be positive or negative? What will be the release? Here bone conduction is more than air conduction. What is normal? This is release positive. What is normal? What is normal? Normal is air conduction more than bone conduction. But here in conductive hearing loss, bone conduction more than air conduction. Okay. Malignant otitis externa, invasive infection causing osteomyelitis. So malignant otitis externa क्या है? Invasive infection causing osteomyelitis. Bone is involving. complication of otitis externa mostly seen in older patients with diabetes. Mostly seen in older patients with diabetes. So complication of otitis externa mostly seen in older patients with diabetes. So it is complication of otitis externa mostly seen in older patients with diabetes. It is mostly seen in older patients with diabetes. So if patient is having diabetes mellitus, then otitis. So otitis externa mostly seen in older patients with diabetes. So if patient is having diabetes, there will be uncontrolled infection. Presence with severe otalgia will be there. Otorrhea means runny ear, okay, like rhinorrhea, runny nose. So otorrhea, there will be discharge. It may lead to cranial disease because the infection is so severe, it is invading the bone, nerve. So physical exam shows granulation tissue in there. You can have, okay, granulation tissue will be there. So let's talk about what is the most common pathogen associated with otitis externa. So it is Pseudomonas. Okay. So you see inflammation of external auditory canal. Pseudomonas most common associated with water exposure, swimmer's ear, or trauma or occlusion, hearing aids. Okay, presence with otalgia that worsens ear with manipulation. There will be pruritus, hearing loss, and discharge. Pruritus, hearing loss, discharge. CDP, you can remember? Or CDP, conductive hearing loss, discharge, pruritus. So malignant otitis externa, invasive infection causing osteomyelitis, complication otitis externa, mostly seen in older patients with diabetes. Patients with severe otalgia and otorrhea may lead to cranial nerve palsy, circumcision, and granulation tissue in the ear canal. Remember that. So what pathology in the ear is associated with water exposure, occlusion, and trauma of the ear canal? That is otitis externa. Then yes, otitis externa, swimmer's ear, and water exposure is there. Okay. What are the clinical findings of malignant otitis externa? So what will be there? Malignant otitis. I'll refer to all the points. Okay. So first, what is malignant otitis externa? It is the infection of the otitis externa in older patients with diabetes mellitus. Okay. So it can lead to osteomyelitis. It can lead to osteomyelitis. And what's the problem? Yes, it can lead to otitis externa. It can lead to osteomyelitis. This is good. Okay, डायबिटीज mellitus है, osteomyelitis है. There will be otalgia and otorrhea. So दोनों में भी रहेगा otalgia and otorrhea. otalgia और otorrhea दोनों में रहेगा. ठीक है, तो कान में से डिस्चार्ज होगा, कान में दर्द होगा, और क्या होगा? osteomyelitis, otalgia and otorrhea. And what? There will be severe pain because nerves are involved now. Severe otalgia will be there and otorrhea will be there. So clinical findings of malignant otitis externa, there will be damage to the cranial nerves, otalgia and otorrhea, discharge pain will be there, and granulation tissue. So it leads to, this may leads to cranial nerve palsies. Okay, granulation tissue, remember that. What are the four clinical features of otitis externa? Same, otalgia, इसमें granulation tissue नहीं रहेगा. Otalgia, otorrhea, there will be pruritus, there will be conductive hearing loss. Okay, these are the four features. Okay, now let's move on to the what are the three common pathogens associated with otitis media. So now from otitis externa we have done where pseudomonas were common and malignant otitis media was there, which occurs in diabetes patients, forming of granulation tissue, cranial nerve involvement, osteomyelitis. Now talking about otitis media. Media में क्या होता है? तो कॉमन पैथोजेंस जो है वो क्या है? So see, ये otitis media. Can you see the findings here in the tryptophan membrane? Okay, so there will be inflammation of middle ear will be there. inflammation of the middle ear. So there is inflammation of the middle ear, most commonly due to non-typable Haemophilus influenza. Inflammation of middle ear most commonly due to non-typable Haemophilus influenza, Streptococcus pneumoniae, Moraxella catarrhalis associated with eustachian tube dysfunction, which promotes overgrowth of bacteria colonizers of upper respiratory tract, usually seen in children less than 2 years old. Presents with fever, otalgia, hearing loss. Physical exam shows bulging erythematous tympanic membrane that may rupture. Mastoiditis infection or mastoid process of temporal bone, complication of acute otitis media, continuity of middle ear cavity with mastoid cells, present with post-auricular pain, erythema, swelling, lead to brain abscess. So what it is here given is, so there is an inflammation मिडिल ईयर. तो जो ओटाइटिस मीडिया में क्या होता है, मिडिल ईयर का इन्फ्लेमेशन, ओटाइटिस आइटिस इन्फ्लेमेशन ऑफ मिडिल ईयर, मिडिल ईयर. ओके, मोस्ट कॉमनली ड्यू टू नॉन टाइपेबल ऑर्गेनिजम्स जैसे कि हीमोफिलस इन्फ्लुएंजा, स्ट्रेप्टोकोकस निमोनिया and Moraxella catarrhalis. So these are associated with eustachian tube dysfunction, which promotes overgrowth of bacterial colonizers of upper respiratory tract. These are the people of upper respiratory tract, but because of the eustachian tube dysfunction, they are overgrowing and the middle ear, usually seen in children less than 2 years old. Presence with, there will be infection, right? So there will be fever, there will be ear pain, otalgia, there will be hearing loss. So physical exam shows this is the bulging tympanic membrane, erythematous tympanic membrane, erythematous, that may rupture. So this is not good, okay? It is rupturing. Mastoiditis, infection of mastoid process of temporal bone. Mastoiditis is the complication of otitis media, which is infection of the itis, inflammation of mastoid process of temporal bone. Temporal bone. Infection of mastoid process of temporal bone. ऑफ मास्टर्ड प्रोसेस ऑफ टेम्पोरल बोन. तो जो टेम्पोरल बोन होती है ना, उसका इन्फेक्शन होता है. तो टेम्पोरल बोन का इन्फेक्शन होता है. सो देर इज इन्फेक्शन ऑफ मास्टर्ड प्रोसेस ऑफ टेम्पोरल बोन. सो मास्टर्डाइटिस में क्या होता है, इन्फेक्शन ऑफ मास्टर्ड प्रोसेस ऑफ टेम्पोरल बोन. टेम्पोरल बोन में जो मास्टर्ड प्रोसेस होता है उसका इन्फेक्शन होता है. Complication of acute otitis media due to continuity of middle ear cavity with mastoid cells. So complication of otitis, acute otitis media क्या होता है, मिडिल ईयर कैविटी विथ मास्टर्ड एयर सेल्स. सो मास्टर्ड एयर सेल्स में इन्फेक्शन हो जाता है. कंटिन्यूटी ऑफ मिडिल ईयर कैविटी विथ मास्टर्ड एयर सेल्स. सो प्रेजेंस विथ पोस्ट ऑरिकुलर पेन, कान के पीछे दर्द होना, एरिथीमा होना, रेडनेस, स्वेलिंग एंड मे लीड टू ब्रेन एब्सेस. अगर ऊपर चले गए तो ब्रेन एब्सेस, बिकॉज इट इज़ वेरी नियर टू द ब्रेन, राइट. So complication of acute otitis media due to continuity of middle ear cavity with mastoid ear cells. क्योंकि mastoid ear cells के साथ middle ear cavity continuity में है ना, इसलिए उसका भी इन्फेक्शन होता है. तो नेम द ऑर्गेनिजम्स, पिछले क्वेश्चन पूछा था. हीमोफिलस इन्फ्लुएंजा, स्ट्रेप्टोकोकस निमोनिया, मोरैक्सेला. ठीक है. डिस्फंक्शन ऑफ व्हाट एनाटॉमिकल स्ट्रक्चर्स, कैटरालिस, मोरैक्सेला कैटरालिस. Dysfunction of what anatomical structure is associated with increased risk of developing otitis media? There is a dysfunction of eustachian tube. It occurs in children. Okay, eustachian tube. Eustachian tube. The dysfunction promotes overgrowth of bacterial colonizers of upper respiratory tract. Promotes. ठीक है. तो ये पॉइंट कहाँ देखिए, देखो इन्फेक्शन, हीमोफिलस इन्फ्लुएंजा, Haemophilus influenza, Streptococcus pneumoniae, catarrhalis due to non-typable. Okay, associated with eustachian tube dysfunction. तो ये है eustachian tube dysfunction promotes overgrowth of bacterial colonizers of upper respiratory tract. Because of eustachian tube dysfunction, there is a promotion of the bacterial colonizers. Seen less than 2 years old. Presence with, there will be fever, there will be pain, hearing loss. Shows bulging after 5 minutes, erythematous tympanic membrane that may rupture. Mastoiditis occurs because of the continuity of the middle ear with the mastoid cells. This is post-auricular pain, erythema, swelling, and may lead to brain abscess. Okay. Next, व्हाट आर द क्लिनिकल फीचर्स ऑफ ओटाइटिस मीडिया के क्या क्लिनिकल फीचर्स होते हैं? तो ओटाइटिस मीडिया में फीवर आएगा क्योंकि यहाँ पे ऑर्गेनिजम्स इन्वेट करते रहेंगे. फीवर, पेन रहेगा, ओटालजिया, and there will be bulging tympanic membrane, there will be hearing loss, of course middle ear is involved. So bulging erythematous tympanic membrane that may rupture. What complication presenting with erythema and swelling in the post-auricular region might arise after an unresolved otitis media, that is mastoiditis? My pen charging is not stable. Okay. ठीक है. Mastoiditis. Uh, what is a dreaded complication of mastoiditis? Dreaded complication is brain abscess, which is very severe. My pen is not working. I have to charge this. Brain abscess. What are the 3 common pathogens associated with otitis media? So we have got 3 components. Okay, we have got Haemophilus, influenza, and Streptococcus pneumonia. Because these are related with the upper respiratory tract because of vesicular tube dysfunction less than 2 years of it. The patient, because the bacteria will colonize and cause middle ear infection, the complication of mastoiditis. Okay, and Moraxella catarrhalis. Okay, 1, 2, 3 organism, HSM, or you can remember like MOSH. Okay, dysfunction of what anatomical structure? We have seen this is taken here. Next. Presenting with erythema, swelling, post-auricular pain, unresolved because of the biliary continuity with the mastoiditis, or the mastoiditis can occur. What the clinical features? See, clinical features important है. Fever होगा यहाँ पे because the organisms involved जो upper respiratory tract करते हैं. Ear pain तो होगा, otalgia, और जैसे सब में होता है ईयर में इन्फेक्शन होगा तो हेयरिंग लॉस होगा, कंडक्टिव हेयरिंग लॉस इन दिस केस, एंड देयर विल बी बल्जिंग एरिथमेटस टिम्पैनिक मेम्ब्रेन. बल्जिंग रहेगा, एरिथीमा रहेगा, एरिथीमा रेडनेस, एंड दिस में कैन बर्स्ट, रप्चर. दिस आर द फाइंडिंग्स. 6 फाइंडिंग्स आ जाते हैं टिम्पैनिक मेम्ब्रेन के बारे में. पेन तो रहेगा. Okay. What is a dreaded complication of mastoiditis? Brain abscess. This is very dreaded complication. Because mastoiditis occurs in the mastoid process of temporal bone. Okay, mastoid process of temporal bone. Just a second. Now moving on to vertigo. So is central or peripheral vertigo more common? Which one is more common? Which one is peripheral vertigo is more common? So let's see vertigo. So we have definition of the vertigo, peripheral and central. What is vertigo? Okay, sensation of spinning while actually stationary. So I'm sitting, but I feel like I'm still moving. Okay, subtypes of dizziness but distinct from lightheadedness. Vertigo is more common than central vertigo. So subtype of dizziness but distinct from lightheadedness. Okay, fine. So now let's talk about it. Peripheral vertigo, because we said it is more common, right? Should know each and everything about it. So it is due to inner ear pathology. So there is a pathology in the inner ear, cochlea, semicircular canals, such as semicircular canal debris. Semicircular canal debris. So due to inner ear pathology such as semicircular canal debris, benign paroxysmal positional vertigo. Due to inner ear pathologies such as semicircular canal debris, benign paroxysmal positional vertigo, vestibular neuritis. So, due to inner ear pathology such as semicircular debris is there, this is called benign paroxysmal positional vertigo. So, what happens is we have this sacral and utricle now. So, they have crista, and then they have calcium carbonate crystals in that, and that unfortunately goes into the semicircular canals inside the semicircular, and because of that they get paroxysmal for a very small time, like for a few seconds they will get on change in position, they will get this attack vertigo. Okay, another is due to inner ear pathology such as semicircular canal debris, vestibular neuritis, and Meniere's disease. Meniere's disease, what happens? Endolymph production is more, it is not able to drain. Okay, so endolymphatic hydrops, increase in endolymph in inner ear. So this is tired of vertigo. What will happen in tired of vertigo? Sensory neural hearing loss will be there. Hearing loss, tinnitus will occur. Tinnitus. Men wear vest. So Meniere's, men wear vest. Okay, so sensory neural hearing loss. So Meniere's disease, what happens? Sensory neural hearing loss, tinnitus, and vertigo. These are the components of Meniere's disease. Meniere's disease endolymph production is more. Because of that, the patient will have sensory neural hearing loss, tinnitus, and vertigo. Okay, so you can remember men wear vest, we vertigo, sensory neural tinnitus. So vest, Meniere's vest. So this occurs more in men now. Okay, findings. So it is mixed horizontal torsional nystagmus. So what findings you will see? So we'll have horizontal torsional vertigo. So this is your cartoonized, and this will be the type of, like, people will be moving like this, okay. So it's horizontal torsional nystagmus. Horizontal torsional nystagmus. Never purely torsional or vertical. Okay, that does not change direction and is suppressible with visual fixation. So when you do visual fixation, the nystagmus will be normal. Due to brainstem or cerebellar lesions, there will be central vertigo. Due to brainstem or cerebellar central. Okay. Example: stroke affecting vestibular nuclei, demyelinating disease, or posterior fossa tumor. These diseases will cause the central. Findings: nystagmus of any direction that is not suppressible with visual fixation. Neurological findings will be diplopia, double vision, diplopia, ataxia, loss of balance, and dysmetria. Dysmetria. Okay, good. So dysmetria, we will not able to know the distance. Most likely in a patient with history of malignancy with the sensation of room spinning, diplopia, and vertical nystagmus. So this is central vertigo. So what is the cause here? Malignancy, demyelination disease, so this is metastasis of the central nervous system and invade the brain cerebellum to produce central vertigo. There is a metastasis. Okay, so due to brainstem or cerebellar lesions like stroke, vestibular nuclei, demyelinating disease, or posterior fossa tumor. So nystagmus of any direction that is suppressible with visual fixation. Neurological findings: diplopia, ataxia, dysmetria. What do you see on positional testing of vertigo in a patient with stroke compromising the vestibular nerve? Immediate dash in any direction. Nystagmus in any direction. So the patient has central vertigo. There will be in it that is not suppressible with visual fixation. Pathology located in peripheral vertigo. This is because semicircular debris. Okay, and vestibular neuritis and Meniere's disease. This is inner ear pathologies. What is the diagnosis of a patient? What is the diagnosis of a patient when a patient experiences sensation of spinning while stationary? So this is called vertigo. This is the definition. While stationary, feeling thud. So this is basically peripheral vertigo is most common than central vertigo. Sensation of spinning while actually stationary, subtype of dizziness but distinct from lightheadedness, more common than central. What is the classic triad of Meniere's disease? The West, there will be vertigo, there will be sensory neural hearing loss, T for tinnitus, there will be sound in the ear. Okay, so here it is given. Vertigo, sensory neural tinnitus. The endolymph will be increased. Pathology Meniere's disease dash increase. Endolymph increased within the inner ear. So this is endolymphatic hydrops. This is basically called as endolymphatic hydrops. Increase endolymph in inner ear. What are the lesions found in patients with disease that cause central vertigo? So posterior fossa tumor, fossa tumor, posterior fossa tumor. What are the lesions found in patients with disease that cause central vertigo? Posterior. What are the lesions found in patients with disease that cause central vertigo? The lesions found in patients with disease that cause central vertigo. Posterior fossa tumor. ठीक है, कौन सा डिजीज posterior fossa tumor करता है? Patients with disease that cause central vertigo. posterior fossa tumor है, और स्ट्रोक की वजह से हुआ पेशेंट को, और demyelinating diseases. So what will be there here? You will see nystagmus in any direction. The nystagmus will not go even on fixation of vision. Okay, and another is on diplopia, ataxia, and dysmetria. Diplopia, ataxia, dysmetria. Brainstem, cerebellum. Brainstem, cerebellum. Brainstem, cerebellum. Okay, brainstem and cerebellar lesions. What are the three common causes of central vertigo? This one, demyelinating diseases, stroke affecting the area, and tumor in the posterior fossa. Vestibular nuclei, demyelinating disease, vestibular nuclei, posterior fossa. Here you can see this. So here, cerebellar or brainstem lesions. Okay, so vestibular affecting vestibular nuclei, demyelinating disease, posterior fossa, tumor. Is central or peripheral vertigo more common? Peripheral more common. Where is the pathology located? It is in the inner ear. Semicircular debris, vestibular neuritis is there because of vestibular neuritis. Semicircular debris is there. Meniere's disease. What do you see on positional testing of vertigo in a patient with stroke compromising the vestibular nuclei? Nystagmus in any direction. What is the most likely in a patient history of malignancy with the sensation of room spinning, diplopia, and vertical instrument? This is because of the posterior fossa tumor, malignancy, metastasis. So that is brainstem cerebellar lesions. What is the diagnosis when a patient experiences spinning or sensation vertigo? By stationary. Okay. What is the classic term Meniere's disease? West is for vertigo, S for sensory neural hearing loss, T for tinnitus. What is the pathology in Meniere's disease? Within the inner ear, endolymphatic hydrops, increased endolymph within the inner ear. What are the lesions found in patients with disease that can cause central vertigo? What are the lesions found in patients with diseases that cause central vertigo? Brainstem and cerebellar lesions will be there, and that is vestibular, involving the vestibular area, stroke involving the vestibular area, and the posterior fossa tumors, and see, stroke involving vestibular area, and posterior fossa tumors and demyelinating diseases. Speed, remember, speedy. Cerebellum. Three common causes of central vertigo we have discussed. Okay, now moving on. Let's start with ophthalmology. Okay, name the components of the anterior segment of the eye that are involved in aqueous humor circulation. So, anterior segment of eye that are involved in aqueous humor circulation. Okay, so let's see. This is the total aqueous humor pathway. Okay, so this is your cornea, this is your sclera, you can see. Then there is a cornea. Okay, and here you can see the ciliary body, pars placata, and this is your iris. Okay, and this is the uveoscleral outflow. So you can see this is the lens, this is the anterior chamber, this is the posterior chamber. So your body is forming like this, it is coming like this and going out, and here is the trabecular meshwork, and here is another color. Okay, so here is the trabecular meshwork, and here is the that is uveoscleral outflow. So now okay, so this here. Okay, so this is your anterior chamber, this is your posterior chamber. Okay, this is your ciliary body releasing the aqueous humor, this is the iris, this is the lens. So this is basically a posterior chamber. So posterior to anterior is coming, this is the trabecular meshwork draining there. Here there is a canal of sclem, to that it is draining. So this is trabecular outflow, drainage through trabecular meshwork to the canal of sclem, episcleral vasculature with M3 agonists, carbachol, pilocarpine. So this mesh of outflow is increased with M3 agonist, carbachol or pilocarpine. Uveoscleral drainage into uvea and sclera. This is uvea and sclera. Drainage to uvea and sclera increased with prostaglandin agonist, example latanoprost, bimatoprost. To uvea and sclera with prostaglandin agonist, latanoprost और बिमाटोप्रोस्ट. ठीक है, यूवी स्क्लेरल आउटपुट कैसे बनेगा, प्रोस्टाग्लैंडिन के वजह से बनेगा. ठीक है, प्रोस्टाग्लैंडिन यूवी स्क्लेरा में जाएगा, लेटानोप्रोस्ट. Aqueous humor produced by non-pigmented epithelium on ciliary body. So this is the ciliary body, non-pigmented epithelium, pars placata. Okay, by decreasing, so it decreases by beta blockers. So how can you reduce aqueous humor? By beta blockers like timolol, alpha 2 agonist like brimonidine, and carbonic anhydrase inhibitor acetazolamide. This will decrease the production. So iris dilator muscle, alpha 1 receptors, and sphincter muscle is what, M3. Okay, so how will you remember this? Dilate is alpha 1, I pick D1, right? And M is sphincter muscle. M3 looks like S, right? So M3. Lens suspended from ciliary body by journal fibers. Lens is there suspended by from ciliary body by zonal fibers. Muscular fibers in ciliary body affects lens shape and position. Shape and position. ठीक है, तो यहाँ पे क्या है, यूवी स्क्लेर आउटफ्लो द components of anterior segment of the eye that are involved in aqueous humor. The ciliary body हो गया, iris, trabecular meshwork, and there is a canal of sclem to the episcleral vasculature, episcleral vessels. Okay, and trabecular meshwork. So ciliary body से iris के उधर से जाएगा posterior to anterior chamber, trabecular meshwork, canal of sclem, episcleral vessels. फिर अगर इधर नहीं जा रहा तो डायरेक्ट कहाँ जाएगा, यूवियर स्क्लेरा में, दैट इज यूवी स्क्लेर आउटफ्लो. व्हाट रिसेप्टर्स रिस्पॉन्सिबल फॉर मिड्रियासिस. मिड्रियासिस नाम बड़ा है तो प्यूपिल का साइज बड़ा होगा. सो प्यूपिल बड़ा हो रहा है, तो पहले प्यूपिल छोटा था, प्यूपिल बड़ा हुआ है. ठीक है, दिस मिड्रियासिस विच रिसेप्टर्स. सो वी नो डायलेटर प्यूपिल, अल्फा and sphincter pupillae and 3. तो sphincter pupillae और dilator pupillae. Dilator तो alpha receptors, alpha 1 receptors to be clear. Noradrenaline binds to alpha 1 receptors of the dilator pupillae, which is intermediasis. Noradrenaline. How do cholinergic agonists cause miosis? How do cholinergic agonists cause miosis? So cholinergic agonists activate dash receptors on the muscle, causing miosis. The sphincter pupillae, which is M3 receptors. So cholinergic acts on M3 receptors. What drug class can be used to increase aqueous humor drainage by the uvea and sclera in patients with open angle? So uvea and sclera by prostaglandin, USP, prostaglandins, that is latanoprost and bimatoprost. Prostaglandin agonist. What drug class can be used to increase drainage of aqueous humor via trabecular meshwork in patients with open angle glaucoma? What drug class can be used to increase drainage of aqueous humor via the trabecular meshwork in patients with open angle glaucoma? What drug class can be used to increase drainage? What drug class can be used to increase drainage of aqueous humor via the trabecular meshwork patients with open angle glaucoma? To increase drainage of aqueous humor via the trabecular meshwork patients with open angle glaucoma. trabecular meshwork से कैसे करोगे, बोलो. What drug class can be used to increase drainage of aqueous humor via the trabecular meshwork in patients with open angle glaucoma? What drug class can be used to increase drainage of aqueous humor via the trabecular meshwork in patients with open angle glaucoma? Class can be used to increase drainage of aqueous humor with the trabecular meshwork. Okay, so trabecular meshwork का increase करने के लिए क्या चाहिए तुमको? That is, you need M3 agonist. So ये है M3 agonist, carbachol, pilocarpine, carbachol and pilocarpine. और यहाँ पे M3 increasing concentration. M3 receptors agonist. So वो M3 agonist चाहिए. agonist हो गया है. So that is carbachol or pilocarpine. What are the What are the two main Pathways whereby aqueous humor drains from the anterior chamber. Trabecular meshwork outflow, trabecular outflow, uveus scleral outflow. So we have trabecular. Trabecular is M3. Agonist. Okay. TM. And other is trabecular M3. Other is prostaglandin uveus scleral outflow. Agonist. Okay. Um, what are the three? What are the three drugs can be used to reduce production of equus in patients with open angle? So you aqueous humor को कम करना है, right? You can use alpha agonist. You can use beta blockers, and you can use inhibitors. Carbonic anhydrase alpha 2 actually. Sorry. One is for mydriasis. Alpha 2 brimonidine. B by brimo aqueous humor or beta blocker. What structure in the anterior eye produces aqueous humor? That is non-pigmented epithelium on the ciliary body. Where is the lens of the eye located? Suspended by the zonules. Ciliary body by zonular fibers, posterior and vitreous chambers. How does the ciliary body help in accommodation of lens to near and far objects? By zonal fibers in ciliary body change the diameter of the lens, shape of the lens to allow for accommodation. Most common presentation of cavernous sinus syndrome. Most common presentation of cavernous sinus syndrome. Most common presentation of cavernous sinus syndrome. Most common presentation. Cavernous sinus syndrome. Variable reduced sensation of vision. This is ophthalmoplegia. Most common presentation of cavernous sinus syndrome: ophthalmoplegia, corneal sensation, hornal syndrome, reduced maxillary sensation. So let's talk about cavernous sinus syndrome. Take a small break. What is the most common presentation of cavernous sinus syndrome? See, cavernous sinus. इससे पहले हमने जो पहले पढ़ा उसको अच्छे से रिवाइज करते हैं. ठीक है, ओके. सो फर्स्ट हमारे पास टेबिकुलर आउटफ्लो रहता है, यूवियस स्क्लेरल आउटफ्लो रहता है. टेबिकुलर मेशो कैनल्स में अभी स्क्लेरल वेसल्स, यहाँ पे यूवियस स्क्लेरल वेसल्स. ठीक है, ठीक है. ट्रेबिकुलर आउटफ्लो काम करता है कौन सा? M3 एगोनिस्ट. यहाँ पे प्रोस्टाग्लैंडिन एगोनिस्ट. एक एक नाम बता दो, एक नाम. M3 पाइलोकार्पिन, प्रोस्टाग्लैंडिन, लेटानोप्लास्ट, हेमाटोप्लास्ट. अब जो एक्वस ह्यूमर कौन बनाता है? नॉन पिगमेंटेड सिलियरी एपिथेलियम. तो ये एक्वस ह्यूमर प्रोडक्शन को कम कैसे करेंगे? अल्फा टू बिमोक्रिप्टन कुछ की है. अल्फा 2 एगोनिस्ट, एंटागोनिस्ट, एगोनिस्ट, बीटा ब्लॉकर, बीटा ब्लॉकर, एंड कार्बोनिक एनहाइड्रेस इनहिबिटर्स, acetazolamide anhydrase inhibitors. Carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. ठीक है, कार्बोनिक एनहाइड्रेस इनहिबिटर्स. ठीक है, अल्फा 2 एगोनिस्ट में बीटा ब्लॉकर, कार्बोनिक एनहाइड्रेस इनहिबिटर्स. नेक्स्ट क्या करना चाहोगे आप? यहाँ पे हमारे मिडियासिस का और यहाँ पे तो कैवर्नस साइनस क्या है? It's a collection of venous sinuses on either side of pituitary. So blood from eye and superficial cortex goes to the cavernous sinus to the internal jugular vein. तो साइनसेस क्या है, ब्लड रहते हैं, तो ब्लड फ्रॉम द आई एंड सुपरफिशियल कॉर्टेक्स वो आएंगे कैवर्नस साइनस में, फिर वो इंटरनल जुगुलर वेन में खिंचाएगा। एंड ऑफ 3, 4, 5, 1, 5, 2 and 6 plus postganglionic sympathetic pupillary fibers en route to orbit all pass through cavernous sinus पे से पास करके जाएंगे। Cavernous portion of internal cavity is also here. So cavernous portion of artery, internal carotid artery is also here. Internal carotid artery भी इधर से पास होती है। Cavernous sinus syndrome क्या है? Presents variable ophthalmoplegia at end of 3 and 6. Decreased corneal sensation, Horner syndrome होगा। Occasional decreased maxillary sensation. एक second. Okay. Secondary to pituitary tumor mass effect, headache, cavernous fistula or cavernous sinus thrombosis related to infection, so due to lack of valves in dural venous sinuses. Dural venous sinus. So ये तुम्हारा क्या है? ये तुम्हारा ऑप्टिक कयास्मा है, किंडर 2 है, किंडर 3 है, किंडर 4 है, किंडर 5, 1, 5, 2 reasons. Anterior chamber, anterior cerebral, internal carotid, subarachnoid, cavernous, arachnoid. जिस ब्रेन को अटैच है ना अरेक्नॉइड से दिया, तो ये बाहर का है। तो ये हमारा इंटरनल कैरोटिड आर्टरी है, थर्ड एंटिटी में एंटीरियर सेरेब्रल आर्टरी है, ऑप्टिक कयास्मा है, और ये क्या है, oculomotor nerve 3, trochlear 4, ophthalmic 5, 1, maxillary 5, 2, abducens 6, sphenoid, ये स्फीनॉइड है, स्फीनॉइड साइनस, ठीक है। और ये हमारा पिट्यूटरी है, collection of venous sinuses on either side of pituitary. So pituitary के either side collection of venous sinuses. So basically this is the cavernous sinus जो blue दिख रहा है। So ये पूरा cavernous sinus है। So यहाँ पे नर्व्स हैं हमारी, देखो यहाँ पे नर्व्स कैसे हैं, ऐसे। ये नर्व 3 है, ये 4 है, 5, 1 है, 5, 2 है, 6 यहाँ पे है, इंटरनल कैरोटिड के नज़दीक है 6, 3 यहाँ पे है। तो जब भी कैवर्नस साइनस और पोस्टग्लैंडियनिक पैरासिम्पैथेटिक भी है, फाइब्रोस एंड रूट to orbit all pass through cavernous sinus. Cavernous portion of internal carotid artery is also here. This is the internal carotid artery. Cavernous portion, ठीक है। So cavernous sinus presents variable ophthalmoplegia in 3 and 6. तो यहाँ पे क्या होता है, कॉर्नियल सेंसेशंस कम हो जाती है और हॉर्नर सिंड्रोम होता है, बिकॉज ऑफ हॉर्नर सिंड्रोम होता है। ओकेशनल डिक्रीज्ड मैक्सिलरी सेंसेशन, maxilla का sensation, और secondary to pituitary tumor mass effect, fistula or cavernous sinus tunnel related to infection due to lack of valves in venous sinuses. Venous sinuses on either side of pituitary. This is a good diagram. Name the component of anterior and right. How do we do it right? Okay, name the component of the anterior segment of the eye that involving aqueous humor circulation. So this is cerebral measure. So we have ciliary body, non-pigmented, and then iris, cerebral measure, kind of skin, wrist diagnosis. What receptors are responsible for mydriasis? alpha 1 agonist, alpha 1, alpha 1, beta acid पढ़ा करेंगे अभी what drug classes what was given here non-adrenaline alpha with the directed of muscle maintenance. What drug can be used to increase drainage of aqueous humor via the trabecular meshwork in patients with open angle? Drainage of aqueous humor, तीन drugs हैं alpha 2 agonist और beta blocker और carbonic anhydrase inhibitor acetazolamide. M3 open angle glaucoma M3. What drug class can be used to increase rates of occasional with the trabecular meshwork in patients with open angle M3? अच्छा क्वेश्चन क्या था इंक्रीज ड्रेनेज ऑफ trabecular meshwork patient अच्छा M3 agonist है increase drainage used to increase drainage of attention whether अच्छा where the trabecular meshwork okay तो trabecular meshwork M3 चाहिए होगा how do you how to cholinergic agonist cause meiosis by M3 sphincter papilla 3 receptors. What drug class can be used to increase aqueous humor drainage by the uvea and sclera? Then you can say prostaglandins, ketanopathy, dermatocyst. Non-pigmented. What are the two main pathways to aqueous humor from the anterior chamber, clavicula, and uvea sclera? The lens of the eye located, zonular fibers, ciliary body. Three drug classes can be used to reduce aqueous humor: alpha agonists, beta blockers, chemical anhydrase inhibitors like acetazolamide. अल्फा 2 का क्या है ब्रीमोनिडीन M3 का पाइलोकार्पिन है ये पाइलोकार्पिन है M3 है which arteries pass through the cavernous sinus which arteries okay कौन से arteries pass through that is internal carotid artery का cavernous part okay internal carotid artery. What are the three underlying structures that cause cavernous sinus thrombosis? Pituitary tumors or carotid cavernous thrombosis, cavernous sinus thrombosis fistula, carotid cavernous fistula or cavernous sinus thrombosis. Okay, cranial nerves 3 आएगा 4 आएगा 5-1A 5-1B 1-2 ओके और यहाँ पे आएगा कितना 6 Out of the pathway of blood from the eye and superficial cortex to the greater venous system. This is via the cavernous sinus to the internal jugular vein. The cavernous sinus is a collection of venous sinuses surrounding what structure? Collection of venous sinuses surrounding what structure? Pituitary gland. Okay. This is in the sella turcica. Pituitary gland. So, what pathogen caused a red inflamed eye similar to that in the image? Any pus or conjunctivitis? What pathogen? Adenovirus. So, this is viral conjunctivitis, pink eye. Most common cause of inflammation of the conjunctiva. Okay. So, this is inflammation of conjunctiva. This is red eye. This is allergic itchy eyes, bilateral. Bacterial pus treat with antibiotics if pus is there. Viral most common adenovirus, sparse mucus discharge, swollen preauricular node, increased lacrimation, self-resolving. I think now I can't speak much. What is the cause of red? How many questions? We have a count of questions. What is the cause of red irritated eye with watery discharge and preauricular lymphadenopathy? Tell me this answer. This is viral. So see here. So इन्फ्लेमेशन ऑफ द कंजंक्टिवा को बोलते हैं रेड आई तो एलर्जी होगी तो बायलेटरल होगा इची आइज बैक्टीरिया में क्या रहेगा बहुत सारा पस रहेगा तो हम इसको एंटीबायोटिक्स देंगे, ठीक है। और वायरल में मोस्ट कॉमन ऑफन एडिनोवायरस रहता है, स्पार्स म्यूकस डिस्चार्ज, तो म्यूकस डिस्चार्ज बहुत कम होगा वायरल में। प्री ऑरिकुलर नोड जो है स्वोलन रहेगा, लेक्रिमेशन बढ़ जाएगा एंड सेल्फ रिजॉल्विंग रहेगा, ठीक है वायरल में। और बैक्टीरिया में पस आएगा, एंटीबायोटिक्स देंगे। एलर्जिक में इची पायलेटर रहेगा, म्यूकस डिस्चार्ज कम रहेगा वायरल में, फिर बैक्टीरिया में पस 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 इसमें कम रहेगा वायरल में। और स्वोलन प्री ऑरिकुलर नोड, lacrimation or self-resolving. What causes unilateral red painful eye oozing pus? Pus bacterial conjunctivitis. तो रहेगा. What is associated with bilateral red eye redness, itching and tearing lasting several weeks? Allergic. How does the ciliary body helps in accommodation of lens to near and far objects? Zonal or fibrous ciliary body change the shape of the lens to allow for accommodation. What is the most common presentation of cavernous sinus syndrome? Okay, so this is variable ophthalmoplegia, corneal sensation, horner and maxillary sensation will be reduced. So यहाँ पे जो लाइन है उसको देखो, यहाँ पे आपको क्या दिया है कि variable ophthalmoplegia can live 3 and 6, corneal sensation, horner syndrome, occasionally decreased maxillary sensation. For 3 underlying conditions may cause cavernous sinusomas: pituitary tumors, carotid cavernous fistula, or carotid cavernous sinus thrombosis. Okay, which arteries pass through the cavernous sinus? Internal carotid artery is the cavernous part, right? Nerves 3, 4, 5, 1, 5 to 6, 3 to 6. Okay, लेकिन फिफ्थ का थर्ड बंच नहीं है. What is the pathway of blood from the eye and superficial cortex to the greater venous system? This is the cavernous cell to the internal jugular vein, via the eye to the superficial cortex to the great venous system, to cavernous sinus jugular vein. What is the cause of red irritated eye, watery discharge and pre-auricular lymphadenopathy? So this is adenovirus viral conjunctivitis. Pre-auricular lacrimation, sparse mucus discharge, adenovirus. Unilateral red painful eye, oozing pus, bacterial conjunctivitis, antibiotic treatment. It's a collection of venous acid sounding word structure. Pituitary gland, Ceratosica, pituitary gland sits on. What is associated with bilateral redness, itching and tearing? तो itching है तो allergic. What person causes a red inflamed eye similar to that image without any pus or thick discharge? So thick discharge नहीं है लेकिन discharge तो है, mucus discharge, adenovirus. So pink eye it is called as viral. Okay. So just a second. What is the prognosis? It is self-limiting. It is most likely to resolve. Without treatment, it will resolve. Pink eye conjunctivitis. What is the prognosis of eye? I have done this. Okay. Now moving on to cranial. A patient presents with the findings shown when looking to the right. What is the diagnosis? So left or right cranial nerve obviously damage. So the affected eye is unable to abduct मतलब ऐसे पीछे देखना, दूर देखना, ठीक है, and is displaced immediately in the primary position of gaze. Cranial nerve 3 has both motor central and parasympathetic peripheral components. One cause include okay, let's do this and after that we'll have huge break. Okay, cranial nerve 3 जो है has both motor 3 has both motor and parasympathetic. Peripheral. मोटर is central, parasympathetic is peripheral. तो कहीं 3 में parasympathetic रहता है. Common causes include ischemia, pupil sparing, motor fibers affected more than parasympathetic fibers. तो okay, motor fibers is more affected. Central motor and peripheral. Uncle herniation and uncle herniation coma. In coma, the cranial nerve 3 will be affected. PCOM aneurysm, sudden onset headache. Cavernous sinus thrombosis, proptosis, involvement cranial nerve 4, 5, 1, 5, 2, and 6. Mid-brain stroke and contralateral hemiplegia. Contralateral hemiplegia. Now discussing about motor. So motor output to extra-auricular muscles. LR6, SO4, others 3. LR6, SO4, 3. So this motor output to extraocular muscles affected primarily by vascular, example diabetes, mucosorbital pathway, polyal pathway we call, due to decreased diffusion of oxygen nutrients to the interior. Middle fibers from compromised vasculature that resides on outside of nerve. Synostosis, down and out gaze is lost. Okay, and the gaze will be down and out. Parasympathetic fibers on periphery are first affected by compression. So fibers on periphery and first affected PCOM and aneurysm, uncle herniation, diminished or absent pupillary reflex, blown pupil, often with a down and out gaze. Diminished or absent pupillary light reflex, blown pupil. Then if 4 pupil is higher in the affected eye, means the head tilt to contralateral affected side to compensate for lack of intorsion in affected eye. Can't see the floor with canal 4. Damage, example, difficulty going downstairs or reading. Pupil is higher in the affected eyes, that's why they can't see down. Characteristic tilt to contralateral or unaffected side to compensate for lack of intorsion in affected eye. Figure 6, affected eye unable to abduct and is displaced medially in primary position gaze. So this eye is affected medially. And this is triangle 4 up. This is up. Okay, this is canal in which there is medial rotation, medially, and this is canal 4 trochlea. So trochlea stairs they can't see. 4 4. So 4 canal 4 damage is there, they can't see the floor. Okay, motor and parasympathetic unclear. A patient presents with the findings shown when looking to the left, which canal nerve is dysfunctional. So this one is trochlea. Left canal nerve trochlea. Looking to the left. This one comes left. Patient comes right hand. The eyes move upward, particularly with the contralateral gaze. You have seen this. A patient right eye is stuck in the position shown. What is the diagnosis? Okay, so it is moving away. 3. Oculomotor nerve. A patient has the findings when asked to look to the right. The movement is impaired in this position. Asking to look its right. And this is its right ear and right eye. Right. So it is not moving right. So abduction is not occurring. So only abduction in the right eye. Cranial nerve 6 palsy. Why are the motor fibers of cranial nerve affected first muscular runs along the periphery of the nerve? Deeper motor fibers. What is the most likely etiology of cranial nerve 3 injury? The disease